Sarah Hahn. I'm a registered veterinary technician and an adjunct professor here at Des Moines Area Community College, the Veterinary Technician program. And this video is meant for the students of DMACC, but of course, anybody is welcome to use it or watch it if you find it helpful for your program as well. Today we're going to be going over the anesthetic machine. We are going to use the one that we have here. Now, generally speaking, we have the same circuit in a lot of our machines, but they're going to look different depending on where you have your machinery at. That being said, because we're dealing with the same type of circuits, you should be able to identify these same parts on your machine that's in front of you. So just going over things real quick, these are our anesthetic masks. We're going to go ahead and move them out of the way so that we don't knock them off or anything like that. With this machine, it does actually have a lot of the same hookups with the ability to switch between non-rebreathing and rebreathing system. This time we're going to use the rebreathing system. As a reminder, the rebreathing system is for patients larger than 15 pounds of their lean weight. And it's going to be useful with either a Y-type tubing or an F-type tubing. So just as a reminder there, this is our flow meter. It's how we are going to be able to titrate our oxygen level to our patient using this knob here. This is our vaporizer. Remember that it is very finely tuned to be able to deliver a specific type of gas to the patient at a specific percentage. Again, it's very, very particular, very, very specialized. So there's our vaporizer here. Here we've got our CO2 canister, usually filled with soda lime, and it's going to be only absorbing carbon dioxide. It's not going to absorb any of our gas anesthetics. So we still do need a scavenging system, even though we're using the rebreathing system. Here's our pop-off valve. You may have one with a, like that you actually have to hold down. This one you can also screw open and shut. When you are starting a procedure, if you're not leak testing, you should always have it open. If you're leak testing, make sure that you open the pop-off valve when you are done leak testing. We've got our inspiratory here and expiratory tube connections that we're going to go ahead and deal with. And then, of course, down below we have our scavenging system. This is going to be our passive scavenging, but we do have a hookup for our active scavenging up in the ceiling. So we're going to go ahead and talk about the different parts, and I'm going to go through hooking up a rebreathing system. When we're hooking up a rebreathing system, you can go ahead and start with a couple of different things. You're welcome to start with the scavenging if you'd like, whether you're choosing active or passive scavenging. So just as an example, and this is labeled very helpfully here, we do have a scavenging opening here. It is labeled, but a lot of our machines it will not be. So we've got our scavenging system here that we are going to hook up to our passive scavenging system here. Of course, if this doesn't fit, you may need to switch around sides, you may need to find an adapter. Again, it depends on your machine and it depends on your system. So making sure that that connection is nice and tight is very important. Obviously, this tube will not work for our use right now. It must be one that we use for the active scavenging because it has a larger opening. Okay, so I ended up using the same hose, but instead of using the activated charcoal in the front, I went ahead and used the part in the back because that hookup does fit. Unfortunately, this is kind of ungainly. There's not a great place for it to be, that it's not kind of in the way of the vaporizer. But you know, you can always get creative with this, trying to pin it around as long as you make sure that your connections are still solid. Next, we're going to do our inspiratory and expiratory tubing. So we've got a couple of different choices. We've got our pediatric and then we've got our adult types. This one is going to be the pediatric F-type rebreathing circuit tubes, and it is labeled, but it is important to know which one goes where. Our inspiratory is going to be the shortest part of it because we want to have that gas be direct, okay? And again, the inspiratory, if you look down the tube itself, you should see the colored part of it. If you have, hopefully you have colors in here. I know some of them are just clear on clear. So you're going to see the inside track of that tube. So that kind of helps you kind of figure out that we want that inspiratory, we want that gas from the shortest distance from machine to patient, okay? So our inspiratory valve is going to hook up our inspiratory tubing is going to hook up here. And then we've got our expiratory tubing down here. Make sure that those connections are nice and firm. And then this end will go to our patient, either, again, a mask or down to an ET tube. Once we have that figured out and we have our correct tubing here and on our scavenging, we're going to go ahead and choose our reservoir bag. So the reservoir bag is going to be based on the patient's lung size. There are calculations for this. There are also general guidelines you can use for size. We'll talk about that separately, so I'm not going to bother you with that right now. And make sure also that you've got the right size here. You can always change these out. If you need to change them out, you're going to use a little bit of firm pressure to pull them off. There are rarely the twist off ones. Usually they're going to be just connected as the tubes are with a little bit of firm pressure on it. So again, making sure that you have a nice tight seal here because we don't want the gas to come through. On this particular machine, we do have the non-rebreathing or the rebreathing system switch here. But the other thing you want to pay attention to is where things are hooked up when it comes to this here. On a lot of these machines, this hookup will change whether you're using rebreathing or non-rebreathing. So on our rebreathing patients, again, it is going to be something where we use the CO2 canister, we use the soda lime to remove the CO2 before we deliver that air back to our patients. In our non-rebreather systems, we don't need that. So in that case, we want to skip this part of the circuit completely. So a lot of times that's why this hookup is different. On this particular machine, it still includes this hookup, but that's what this switch is for. It's to reroute it past all of this and deliver it right back into the patient, making a smaller circuit so that their little lungs don't have to make up the difference in pressure, okay? Again, we're just making sure that we can follow the trail of oxygen through the system, okay? So bear with me as we go ahead and follow this through step by step. For our oxygen, we have our oxygen source. It is going to be hooked up usually to a central source, but if you do not have central lines, which some places don't, then a lot of times you'll have an E-tank down here that's going to be attached very firmly to the system. As a reminder, these oxygen canisters are pressurized, so they need to be attached to either the wall or firmly bolted to the machine, because if they were to fall over and break open, it is very dangerous. So just keep that in mind. So we've got our oxygen supply going here. If you notice, you can actually see the innards of this particular machine. It may not always be obvious in your machines here. So if you notice, kind of hard to visualize, so I'll do my best for you here. There is an area back here where it can be rerouted. Instead of going up here through the flow meter, it can be bypassed here, and usually in order to do that, you would use the oxygen flush valve, which is here, okay? So when you push this button, you are completely skipping all of this and you're rerouting it directly into the inspiratory so that it's delivered directly to the patient. It is not going through the vaporizer. Again, we never want to use the oxygen flush when we are hooked up to a patient, okay? The oxygen flush should only be used when we're doing blow-by oxygen or we are flushing a system, hence the name, or we're doing a leak test, because as a reminder, this flow meter is titrating down the high pressure that we have in our central oxygen lines or in the tank itself down to a safe, usable pressure for our patients and for their lungs, the safety of their lungs, okay? So if you have an animal hooked up to the machine and you use the oxygen flush valve, you are completely bypassing the safety measure, and you don't want to do that. Obviously that can cause harm or death to the patient, so keep that kind of stuff in mind. When you're using this without the oxygen flush valve though, notice that it goes here through the flow meter and then up here through the top and down into this tube here, okay? Again, it goes up to the flush valve here, or it goes directly into the flow meter, goes through here, comes out here, and down to the front, which is gonna be here. It's going to go through here, and think of it, the oxygen like a car, right? Picks up the passengers here, and then it comes out here. Now, when we go into this area here, This is where we have the bypassing from either rebreathing or non-rebreathing, right? So we have it on rebreathing. That means that it will continue through here, up here, and right into the inspiratory, okay? Remember, our goal is to have the smallest amount of travel time between the oxygen and the anesthesia in our patient, so the minimal amount of dead space. So it's going to go through the inspiratory line to the patient. The patient will breathe it through this central tube, and as they breathe it back in, it will go in the outside of this tube, and it will come down to here. Now, as you can obviously tell, there's not a great separation between this two. That's another reminder that this is a rebreathing system for a reason, right? However, a lot of the expired air by pressure alone is going to come on this outside tube, and it's going to come in through here. It's going to go through, so again, follow it down, up, and then back through the inspiratory, adding and merging with the new gas that's coming in, okay? In the meantime, a lot of it is getting down into this reservoir bag as well, and it should be about 3/4 full if you calculate it properly for the patient during their max exhale, okay? We never want it to its maximum filling size. That means that you underestimated how large the lungs are, and you might need to switch out for a larger bag. However, if you calculate it correctly, then it will come through here, up through the canister, soaks up all that CO2. What's left is the gas anesthesia and what's left of oxygen. It's going to go through here and then back again, merging with that fresh gas and back into the patient. And it just continues like that. This pop-off valve is going to stop the flow from coming and merging with the new stuff. So it's going to hit a dead end here. And that's part of how we do our leak test, is that we are stopping that flow, and we are causing it to basically be at a standstill. It will fill up this bag, and then we stop the flow itself, so don't add any more cars to the circuit. And then we see if basically the bag can hold that pressure. This is our manometer, and it's going to be telling us the pressure of the circuit itself. You never want to bypass 15 to 20 centimeters of water, because we don't ever want to risk the patient's lungs. When we are doing a leak test, the absolute maximum that you should ever hit is 30, but even then I wouldn't push it. Shoot for 20 centimeters of water. It should be able to hold that pressure for 15 seconds minimum, okay? When you are giving breast to the patient though, again, you do not want to bypass the number 20 on here, okay? So our manometer is going to tell us the pressure of the system. It's going to let us know if we have too much pressure that would be a danger to the patient's lungs. So keep that kind of stuff in mind if you ever have to give manual breaths or size to your patient, because we want to put their safety first. Okay, so now that we've talked about rebreathing, we're going to go ahead and do our non-rebreathing. I went ahead and removed these so you can see a little bit clearly what we're talking about here. So we've got our scavenging system here. We want to go ahead and disconnect that, because again, we are bypassing this part here. We're not using the CO2 canister, we're not using the reservoir bag, we're not even using the manometer. So we are going to go ahead and disconnect that, because we do not need that for this system, for this circulatory system. Okay? So for our non-rebreathing, you should have some sort of manometer on here with a manual pop-off valve, something that's supposed to hold the air in the circuit so that you can give breaths, or you can leak test, which is going to be vital. This is going to be your scavenging hose, so you will hook this up to your canister instead of the larger one that hooks up here, because remember, we are just trying to finish the circuit and make sure that we are keeping our patients and our staff safe. Okay, so I've got that hooked up here, down there. And here I've got to have, so this goes to the patient, so we're not going to worry about that, but I do need to have this hooked up to our oxygen. As a reminder, this particular machine requires you to switch it to the non-rebreather system, and we have the non-rebreather attachment here. Every machine is a little bit different. Sometimes it will be disconnecting this part here on the vaporizer and hooking it up there. Sometimes it will be disconnecting this hose and stopping it before it goes into this part of the system and hooking that up instead. In this particular machine, because of the switch, it's going to be here, okay? So now, as a reminder, our system is still following the same oxygen flow. It goes through the vaporizer, and now that it hits this redirection, instead of going out this tube and into the rebreathing system, it's going to come out this tube, and it's all going to go in here. As a reminder, at this point, it has gone through here, it goes into here, and it either goes up this into the rebreathing or it goes into this non-rebreathing. We're doing non-rebreathing this time. So now we'll have this hooked into the patient. This is going to be our fresh oxygen and anesthesia inlet, and then when it's exhaled, it's going to go through here and immediately out, like in the reservoir bag, down, and immediately out through the scavenging. That's part of why this is called a non-rebreathing system. The other reason is because the flow has to be higher so that we're keeping the pressure delivered to our small patients. They don't have the lung strength and capacity that our larger patients do. So they're unable to maintain the pressure that's required to help them breathe easily. So for that, our oxygen flow needs to be a little bit higher, and in that case, we see cooling of the patient. We see the anesthesia be delivered faster, so we see those changes happening faster, things like that. Our non-rebreathing system is pretty easy to hook up. You may still need to change your bag size. Again, it's going to be calculated based on the patient's lean weight. And then of course you have your manometer here. When you are checking a leak test, so we'll actually, when we actually do the leak test, your goal is to plug this outlet, okay? Usually you can use the meaty part of your hand to plug that. And then you are going to turn on the oxygen, so it will be hooked up. And then you are either going to turn on the flow meter if you're using this, or if you're using the rebreathing system, which again is larger, you may need to use the flush valve to get a little bit faster flow to fill up that bag and that system a little bit faster. Again, for our littler systems, our non-rebreathing systems, you shouldn't necessarily need the oxygen flush valve. That might be too fast, too much too fast. So just kind of keep that stuff in mind. When you do the leak test, again, you are looking for this manometer to hit 20 centimeters of water, and you want it to hold that for at least 15 seconds. So if it doesn't, then you will need to go and check all of your attachments and see if you can figure out where the connection is not good. So it might be a bad connection between the tubes on here, it could be a bad connection or covering of here, it could be a bad bag, and that's when you're going to troubleshoot using your knowledge of how this circulates through the system and to the patient.